This is Danny Bobrow, President of AIM Dental Marketing, welcoming you to this installment of the Practice Perfection web-based education series. Back after a long hiatus, as exemplified by today's presenter, we're grateful and excited about being able to once again deliver these learning opportunities with some of the true luminaries of the dental industry and profession. Today's presentation is entitled, Keep Your Head Out of the Clouds, but Not Your Practice. Jeff Burton is the founder and CEO of Lyon Dental, dedicated to advancing the standard of care in dental practice management. Jeff will provide insight into the world of medical billing and documentation requirements for dentists whose focus is on oral appliance therapy and craniofacial pain treatment, which places it squarely within the oral systemic practice model, and is why I'm so excited to be able to share Jeff and Lyon Dental with all of you. His company, Lyon, worked with medical software developers to build a unique platform called MD Fusion, a cloud-based electronic health records, or EHR, software that is critical to successful reimbursement and compliance with health insurance policies. Billing services operate on the same platform and in so doing fully integrate clinical documentation, scheduling, patient demographics, insurance, and other key elements, resulting in efficient planning, delivery, and timely reimbursement of treatment. Jeff presents the policy, licensure, enrollment, fees, and participation issues, as well as legal considerations, and the current and projected landscape of health insurance in the United States to help chart your winning course through these sometimes confusing medical reimbursement waters. His training as a critical care nurse, coupled with a solid grounding in business management, enabled him to see and solve the challenges facing private practice dentists in balancing the clinical and financial sides of the treatment coin. The result is Lyon Dental. Jeff has held management positions at Blue Cross Blue Shield of Michigan, the Blue Cross Blue Shield Association, Physicians, an independent physicians organization in Southeast Michigan. As an attendee today, you will learn the fundamentals of medical and dental insurance and the important differences between the two. You will also learn the importance of accurate and complete documentation, including the provider's notes, how the use of a comprehensive cloud-based EHR can be the difference maker for a busy dental sleep program, and common procedures not covered by dental insurance, but reimbursable by medical insurance. In short, the must-knows before getting started with medical billing and how to minimize the accompanying financial and legal risks. Before we get started with today's event and very special presenter, I want to remind you, because it's been a while since we presented this, Practice Perfection webcasts run for around 90 minutes. Now, while attendees are in listen-only mode, we invite you at any time to submit your questions or comments using the question button on your screen. We will allow time following the presentation to get your questions answered. If we do not get to each of your questions during the webcast, you have my assurance that we'll see they're answered shortly thereafter. Attendance at this presentation entitles you to receive 1.5 hours of continuing education credit with the compliments of Lyon Dental and AIM Dental Marketing. Shortly after the webcast, you will be emailed a brief survey and quiz to complete and receive your CE, again, at no cost to you. Participants are cautioned about the dangers of incorporating techniques and procedures into their practice if the course has not provided them with adequate clinical experience to allow them to perform them competently. And now it is my distinct pleasure to welcome to the Practice Perfection stage my friend, Jeff Burton. Hello, Jeff.
Hi, Danny. Thanks so much. I appreciate the AIM Dental hosting this great webcast, and thanks everybody for joining us here on Thursday night. I'm Jeff Burton, founder and CEO of Lyon Dental. Hopefully I can teach you and guide you tonight the world of medical billing and all of the elements, including documentation, software support, and some of the other financial, legal considerations. I am not a lawyer, and I'm not a financial analyst or certified financial analyst. So all the information is from my experience as founder of Lyon Dental. As Danny had mentioned, I've got some experience working for the Blues here in Michigan. It's where I'm located. Also the Blue Cross Association with a physician organization called United Physicians. So I've got quite a bit of experience on the medical side and came to found Lyon Dental in 2015, helping a handful of offices in Michigan grow their dental sleep program. And that grew into a much larger business where now we have a software platform and medical billing services that provide some value to dental offices in the primarily in the dental sleep space, but now growing into other dental procedures that are billable to medical insurance. I take a pretty hands-on approach with our clients, and my staff has a lot of combined experience within the medical field as well, as you see here. So we try to take a very professional approach to consulting and providing our professional medical billing services and software to the dental community. And we recently launched our practice management software called MD Fusion. It's built on a certified EHR, electronic health records, or some people refer to as electronic medical records. And that's really to support our practices with all of the documentation requirements and everything else to keep track of as they go about trying to get reimbursed for oral appliance therapy. So today we're going to cover a few important topics or learning objectives. Talk about the fundamentals of medical insurance. What are the big differences from what a typical dental practice would be used to and working with dental insurance, and what you need to know before you get started. Some common conditions and procedures that are covered by medical insurance, and what's the value? Why would you even consider taking medical insurance? We're going to talk a little bit about how an EHR, electronic health records, in our case and in most cases here, we recommend a cloud-based system, could be the difference maker when it comes to all of the documentation and management of new requirements you might have when performing these procedures. And finally, some tips to minimize some financial and legal risk that comes with the territory of billing medical insurance. So why? Why would we even talk about this? Why is it a topic? Well, the future really, dental offices are expanding their role. And as Danny had mentioned, is very involved in the oral systemic health. There are the problems that patients are presenting with are more complicated, and insurers, payers are looking to medical benefits to cover some of these procedures that dental offices would provide treatment for. There's more reliance on billing these medical plans. Dental offices are then forced to adopt new guidelines and learn the medical policies that the dental payers won't pay for services, so it's shifted over to medical. And now dental offices have to take on some new resources, skills, knowledge, vendors to be able to accomplish what they need to be successful in reimbursement. And software programs are becoming more advanced. Our program, the future, is incorporating both dental and medical charting, all of your clinical documentation and billing. We'll talk about that a little bit more, but the software platform seems to be one of the key elements to bring everything together. So here are some important concepts to, I guess, that will be prominent through our presentation here tonight. These will also play out in your practice if you are currently providing a treatment that crosses over into the medical space, or if you're considering this. These are some fundamental concepts to make sure you're aware of. So first, there's, like I'd mentioned, increasing medical insurance coverage for certain dental procedures. We'll talk about some of those procedures here on our call. The knowledge of the marketplace. What are other dentists doing in your area? What kind of patient population do you have? These are very important things to know, often overlooked because you have an established practice. However, when it comes to participation, when it comes to treating some of these other conditions, I'll make a lot of reference to oral appliance therapy because it seems to be a very popular option for dentists these days. Your patient population is much different. You're not treating your typical dental population. You've got maybe an older population with sleep apnea, so something to consider. Some of these treatments may require board certification or some type of a professional certificate. So payers are starting to look towards the professional societies that might be issuing such continuing education and maybe even beyond, and some type of professional certificate or even a board certification. I anticipate this is coming for sleep, as there are some pretty robust policies and guidelines that have been issued by AADSM, American Academy of Dental Sleep Medicine. So this is something that, as you look to expand your practice and provide some of these treatments that cross over to medical, this might be a requirement in the future. Certainly Medicare. This is now a new world for the dental practice and working and dealing with Medicare. And sometimes you can't avoid it. The patients come with Medicare and you have to figure out what to do. What are you going to enroll with Medicare? Are you going to be able to bill Medicare? Do you have to turn these patients away? It's often hard to bill a Medicare patient as a cash-only office. And once again, this is a different population. And with the Medicare patients, there are many stringent guidelines. They have some detailed policies and regulations you need to be aware of. We'll get into some of these detailed requirements here later. And there are many plans in the medical insurance world, probably more than what you're used to in the dental office. So you have a wider range of plans with a wider range of coverage. So one patient might have very rich benefits with coverage at 100%, and then the next patient with the same plan walks in and they are only covered at 50%. Higher medical premiums. So this is not a secret to anybody. It's putting a lot of pressure on the patients to utilize the insurance network. So they're footing a bill for their medical insurance every month, and they'd rather work with a provider who is in network, obviously. Just as you were going to your doctor and seeking any type of medical treatment, you're looking for someone in your network. That's the same thing that your patients that are seeking these medical treatments are looking for too. Oftentimes we see referral volume from the physician community increase if you, quote, take insurance. And then there's often a complex claim preparation and a claim submission process with an emphasis on the documentation from the dental office and any other supporting documentation coming from the physician. So that's really important. And for that reason there, among the other reasons, is why you may consider investing in a system or some additional resources to help keep track of all this and help with the reimbursement. So inherently two different worlds here in dental and medical insurance. So on the dental side, benefits are more straightforward. Oftentimes, dental offices are fee-for-service. Cash for your services is more common than it is in a medical office. Billing is more straightforward, and you get your pre-D, and you know to the penny what the insurance is going to cover and what the patient has out of pocket. Easy peasy, and you're done. Now, medical insurance, on the other hand, you've got many different benefit plans. Dentists often have some challenges trying to participate with these medical insurance. Some opt not to. There's alternative payment models that these medical plans have. The coding and the diagnosis and the proof of medical necessity for what you're doing is often a burden on the dental office. And you have pre-authorization, you have to deal with the denials and appeals. Not that that doesn't happen on the medical side, but it's quite a bit more in the claim process. And then there's Medicare. So, who's going to help you successfully navigate medical insurance? Is your staff equipped? Do you have the right systems? Do you have a team? Maybe it's a third party. Maybe it's a vendor within the industry that's working on your behalf. So typically, an office is looking at, well, if I'm going to consider getting into a treatment that I know is oftentimes reimbursed by medical, am I going to take insurance and go this route and hopefully get higher reimbursement and higher case volumes, or do I not want to deal with all that stuff and focus on cash? So what obviously you have to focus on for your practice, what tips the scale. I can tell you from experience that the higher volume is definitely seen with practices who are willing to take insurance and work with insurance in some capacity. That doesn't mean take every plan and take every insurance, but not only the patients shopping around for the highest quality and the best price, but physicians are oftentimes more likely to refer to your practice if you take insurance. On the other side of the coin, you got a shorter revenue cycle, less regulations and policies you have to deal with. Your reimbursement and your price as far as what's out of pocket for the patient is pretty much straightforward when you're dealing with a cash-only practice. Every practice should go, if you're getting into a certain treatment like sleep or TMD, management for craniofacial pain, you have to run a cost-benefit analysis. So you have to understand there's going to be some enrollment fees. Whether you set up, software, you have a billing service, you might have some additional training for your staff. There might be enrollment. You might have to pay somebody to help you to get enrolled and participate with plans. So, going into this with the knowledge of, hey, I'm going to have to invest some money into this. And then my ongoing cost of doing business, it might be software and billing. You probably want to figure about 10% of what your total collections are going to be. You're going to spend on software and billing services. If you are, fully engaged in a treatment, you've got classes and seminars, you might have some more marketing expenses, maybe you have to hire another staff, or maybe you have to provide some extra training for your staff. The benefit, obviously, is, there's some pretty good reimbursement for some of these dental procedures. Surgical procedures come with a higher reimbursement. Dental sleep medicine, so the oral appliance therapy for sleep apnea, is the reimbursement is becoming a little bit more normalized. So if you can contain your cost and run your practice efficiently, there's a pretty big benefit sitting there as far as the reimbursement for these services from medical insurance. Your practice might be more marketable, and you might even attract dental patients. Patients maybe who don't have an established dentist, who come to you because you're providing a special surgical procedure or lab testing or oral appliance therapy to treat whatever condition they may have. Maybe their dentist isn't doing that, or maybe they don't have a dentist and they're looking for a new dentist. So it could be a way, not that I'm telling you to go and try to sell your dental services to patients who are seeking you for your specialized dental treatment for medical, but it could be a passive result of that. And then obviously you're expanding your professional skills and helping patients.
Right. Just a brief comment on that, what I think is pretty much apparent, but you have to consider the source of the patient. If you're getting referrals from a physician, which is ideal and less complicated, it's simpler but not necessarily easy. And we talk about the protocols to make those connections. But that's a really good way to get a patient who is not just going to come for that treatment, but will stay for the general dentistry services. That's in contrast to the situation where a fellow dental practitioner refers to you for that reason. But that's not typically what we see as a large segment of the sources of the referrals. But if you do that, then obviously you have to respect, and unless you don't want to get any more referrals from the dental community, you want to make clear that they come to you for that treatment, and then you respect the integrity of the relationship, and then send them back to the referring the dental professional. But just wanted to make that clear.
Certainly. Hey, thanks for the comment there, Danny. That's very helpful and I think spot on. So, if you're considering treatments or you're providing treatments, maybe you didn't get off to the start that you wanted to. Obviously, this year has been a weird year for everybody. So whether you're currently providing one of these treatments that crosses over to medical, or you're thinking about getting started, what are the things you need to maybe consider first? Some of these I mentioned as our fundamental concepts. You want to explore what your peers are doing, particularly in your area. There are pioneers of some of these industries, just like there were for implants. A lot of dentists learned what to do and what not to do from some of the people who started doing implants. Same thing goes for TMD treatment. Same thing goes for sleep. Same thing goes for some of these other advanced procedures. It could be a surgical procedure, or just a standard dental procedure that has the possibility of crossing over to medical. What are other people doing? What kind of education are they getting? Are they getting it with insurance? What are your continuing education opportunities, and who are the consultants and vendors in your area? That's within the industry, I should say. It's very important to know. Finding the right vendors and partners can really help turn a practice around. So I want to stress that. And what are the clinical guidelines? Is it within your scope of practice in your state? Are there legal considerations? I always tell people, before starting a new treatment, especially when it involves billing and setting up policies, especially if you're going to be working with Medicare, talk to a healthcare attorney. It is a valuable investment that might save you huge in the back end. Identify the common medical insurance plans in your area. So, what insurance do you have? What insurance does your family have? You may have an idea of who the biggest or most the payers in your area that have the most membership. This is a link here, and Danny, I believe we're going to be sharing this presentation afterwards, so people would have the ability to click on links. Is that correct?
We will be sending a recording of the webcast. What we can do, because I was considering that myself while going through it, I think we can arrange to just copy and paste those into the follow-up email. So yeah, sure. I would consider that done. Because I think
Excellent.
That's a really nice resource to share for sure. I was intrigued by it. I even signed up to get even more email alerts because of it.
Well, very good. So the Becker Hospital Review here is I've combed every resource to try and get an idea when we have new clients sign up, and someone happens to come from an area or a state that maybe we don't have a lot of experience in. One of our first lines of business is to understand what are the major payers, because that really drives everything. What are their medical policies? Do they cover it? What do they pay? So there oftentimes is a huge knowledge gap. When I ask some of my clients, who are your major payers if they're just getting started, usually it's I don't know. I'm depending on you to answer that question. So, a medical billing service can help you do that, but, why not have the knowledge yourself? This is a really good resource here. And then start to explore opportunities to participate with some of these plans, which obviously means contracting with the plan and joining the network. This is possible for some dental plans. Now, for some dental providers, if you're offering a standard dental service, so maybe you're doing some extractions, or you're doing some biopsies, or you might be doing frenectomies, do you really need to go and contract with a payer for that? Maybe not, because oftentimes if the dental insurance won't cover it and you've got the medical diagnosis, you can flip it over and they'll make an exception. However, if you're providing services on a more regular basis, which is, the whole reason why we exist and why you would maybe consider listening on this presentation today, it might be a good idea to start that process and know what the terms of some of these participation contracts might be. Just know that the whole process can take anywhere between 60 and 120 days. That's quite a bit of time, and that's standard. That's what all medical practices go through when they open up their doors and say, okay, look, we're gonna take all the major insurance, and this is what they have to go through. Also, the Medicare application. This applies a little bit more for dental sleep medicine. If you're going to become a durable medical equipment provider, this is a pretty intense application process. So just know that it takes some time and some attention. A little bit more on the enrollment and credentialing before we get into some other fun topics here. Make sure your fees are reasonable and customary. Go through a process and be strategic about setting your fee schedule. You may want to have a couple different fee schedules, so I recommend if you're going to be offering services to patients who don't have insurance, or maybe you don't take their insurance, you should have some type of a cash fee schedule, and then you should have your standard fee schedule that you build as a plan. We'll get into the fees a little bit more, and then start looking at the Medicare fees as a point of reference. So Medicare on their website, you're able to search by code and by region as far as what Medicare would pay a professional practice, different than a hospital. So the Medicare fees should always be your starting point. And you always, of course, want to make your fees higher than Medicare, but also higher than what the highest commercial payer will pay. But don't be an outlier. So again, it's a process, and you got to apply some strategies so your practice doesn't throw up red flags when you start billing to a new medical insurer. It's also very important that you update your NPI records. Now, if you're working with a billing service, they might offer this. We do to kind of help you along here. But any health plan, including Medicare, the first thing they will do is look up your NPI in the NPI database. It's a national public database. And it's not only your individual NPI, but you may want to obtain a group NPI, or some people refer to this as a billing NPI. This I recommend getting if you're going to be billing any type of medical insurance, particularly if you've got a group practice where there's multiple dentists that obviously have their own individual NPIs. The group NPI follows the group, the practice. And that's what gets submitted on the claim for payment. And there's something called CAQH. It stands for the Council of Affordable and Quality Healthcare. The CAQH, if you're an ADA member and you've signed up through the ADA portal, you may have noticed that CAQH, you might have go through a short process to establish a CAQH profile. This really is used as a source of truth for for many commercial payers when they go through this enrollment and credentialing process. And you have to attest that all of your information is accurate and up to date every quarter. So these are some very important things if you're going to get started, or maybe you have started and you're struggling. These are some fundamental things that you should consider in tandem with your billing service if you have one. Now we're going to talk a little bit about the types of plans, and we're going to get into some scenarios about fees, and then we're going to get into more about the which procedures are covered and how software can help. But it's really important to just kind of building on what we've been talking about already is building your knowledge base. This is where we find the most gaps as far as barriers to reimbursement. The dental office doesn't necessarily know what types of plans they're working with. Maybe they haven't gone through a process to understand what their fee schedule should be. So this is obviously important why we include this information. You can break the plans down. I like to break them down into 3 different sectors. So you have your government plans, Medicare at the federal level, Medicaid, which is always state sponsored, and then TRICARE, which is active duty military and retirees and their families. Then you have the national plans. These national plans are typically all for-profit. So you have United Healthcare, Aetna, and Cigna as the main three national plans. And then you have your other local plans. So the local plans are specific maybe to a region or a state, like a Blue Cross Blue Shield plan, or you might have some other small regional plans that are unique to your area. There's a couple plans here that are very important to understand because they operate a little bit differently. And the first one is the HMO plan. The HMO plan, different than the PPO plan, HMO plans typically do not have any out-of-network benefits. They always require some type of a pre-authorization. And if you're going to be starting services like an exam to see if the patient is a candidate for treatment, they will often require the PCP, the primary care physician, to write a referral. Some of these plans have this, they refer to it as the gatekeeper. That's what HMO plans are referred to. And the PCP, the primary care physician, is the gatekeeper. So they will control where they approve this patient seeking care from a specialist. And that's what you, as a dentist, would be considered as a specialist. So this is an important concept just to understand. We don't need to go into the details of why, but if you see HMO patients, you need to apply some special attention to their plan, especially if you're an out-of-network provider. Now, Medicare and the Medicare Advantage plans are also there are two different types of plans, but they're all sponsored by Medicare. That's the other payer type that you really should understand. So the summary of this slide is that Medicare enrollment is growing. By 2050, we should see year over year here a continual increase in Medicare enrollment, and that's simply because obviously the population is getting older. And as that happens, we're going to end up with, a flat line of a lot of Medicare people, but, enrollment will slightly go down because there's not going to be new people getting into Medicare. So it's a kind of an inverse relationship, what you see in this graph. Bottom line is Medicare is going to be a huge part of any type of a practice that's going to be billing for medical services. And Medicare is it's an interesting plan because you have the regular Medicare benefits that are offered to people who age into Medicare. So if you're 65 or older, or you could qualify with a disability or through low income, which typically you would be in a Medicaid plan. But there's some other qualifications with Medicare. Typically, when you say Medicare or you see a Medicare patient, they're over 65. There are standard benefits that are offered to them by the federal government that they've paid into. Is Part A and Part B. So Part A covers all their hospital stuff. Part B covers doctor's visits, supplies, preventive services, surgical procedures, etc. There's a standard Medicare benefit. The deductible is very low. It's about $200. Medicare covers 80% of every one of your services, and then you as the patient are responsible for 20%. Now, the patient has an option to choose a Medicare Advantage plan as opposed to the regular Medicare coverage. Their premiums might be a little bit higher, it depends, but Medicare Advantage plans are Medicare-sponsored plans. They follow the same rules. They often follow the same reimbursement to you as a provider. However, they provide the member or the patient both Part A and Part B coverage, plus prescription drugs and some additional benefits like vision, possibly dental, and maybe some other wellness benefits. That's what they refer to as Part C, the Medicare Advantage plan, and it comes from a private payer. So when the patient hands you a card, you'll see Blue Cross Blue Shield Plus, Blue Plus, or Medicare Advantage, or MA, and that's what those plans are. Patients who opt for regular Medicare may add a Part D prescription drug coverage, which might not be too relevant here in our conversation. But they also may add a Medicare supplemental plan, which is also known as a Medigap plan. This basically picks up the remaining 20% that I was referring to when you utilize your regular Part A, Part B benefits, paying for an additional supplemental plan. If you're going to have a lot of procedures and or care, it might be a good idea to opt for this additional coverage. Just a little bit more about the Medigap plan and how it's different from Medicare Advantage, because people oftentimes confuse these. So the Medigap plan simply, like I stated, covers that additional 20%. So there's some additional premiums. And the Medicare Advantage plan is a full Medicare plan plus all these additional benefits, and all of your policies and your benefits are structured by the private payer, like a Blue Cross or like United Healthcare. So two different plans there. The Medigap or Medicare Supplemental is different than Medicare Advantage. Now, this slide is to show you that Medicare Advantage is the fastest growing segment of any health plan compared to PPO, HMO, point of service plans, and regular Medicare plans. So this is a graph here from 2019 that'll show you of all the Medicare beneficiaries in each state, how many of them have opted for a Medicare Advantage plan. So you can see your state there, and this number will be growing exponentially. Now, that's kind of a summary of all of the things to consider. You know, what types of plans how do I get started, how to consider enrollments. At the end of the day, you're still going to have to make a decision. Do I take insurance or not? This is all good. I understand this, but I'm still not quite sure. I need some hard numbers here to understand. This is an example of a case. It might be a surgical case or advanced surgical case. It might be an oral appliance case. So let's just say you're setting your fee for $3,000 for a particular service, and the health plan that maybe you're considering participating with has an allowable amount or contract rate of $2,000. So your charge of $3,000 in a scenario, there's three different scenarios here. Scenario one, you accept the fee by joining the network. You say, okay, look, I realize that the $2,000 is a good rate. I would rather join this network and see the volume. Option two in the middle, you do not accept the fee. You're an out-of-network provider, but you still want to utilize the medical insurance benefits that the patient might have, even as an out-of-network provider, which is fairly common among dentists. And then option three would be complete fee for service, where you're billing the patient your full fee. Now, in this scenario here, you notice that the provider charge is different. It's $2,500. This accounts for the fact that many offices may offer a prompt pay discount or a cash discount. We like to say prompt pay. That's a recommendation from many different legal and financial consultants that we've worked with, simply because you're foregoing the revenue cycle time to have medical insurance pay. You're foregoing maybe the additional fees to submit and prepare claims. So it is appropriate for you to offer a discount within reason. There are some case precedences with larger hospital systems that were offering significant discounts, and health insurers filed suit against those hospitals because their discounts were so egregious. They argued that your fee is not really your fee at all. You're discriminating against these insured patients and charging us, the payer, a lot more than what you'd typically charge a patient that walked through your door who had the same service but might be paying cash. So be very careful about prompt pay cash discounts. They should be within reason. My recommendation is 10 to 20%. I am not a financial analyst. I'm not a lawyer. This is what we would recommend as a billing service. And then we recommend never to waive any copays or deductibles. So if you're going to be billing insurance in these first two scenarios I'll get back to, you have to follow whatever the health plan states on their remittance. So that EOB that comes back to the patient, or the electronic remittance that comes back to your billing company or you, will tell you, okay, we paid this much. The patient, has a deductible remaining, and after that we'll cover it at X percentage. So the first two scenarios here are the health plan covering their allowed amount, and then in both scenarios the patient might have a different total out of pocket. So I use these numbers just kind of based on what we see as an average as far as those percentages. So in scenario one, the health plan pays $2,000. Typically, we see an 80% payment from insurance. The patient would be left with 20%, which, again, we're only working off the allowed amount. So that $1,000 difference between your charge and the allowed amount is written off. This leaves you as the provider with a revenue of $2,000, $400 collected from the patient, $1,600 collected from the insurance. We typically see more acceptance of these cases. So if you're presenting treatment to your patient, or you're looking to grow your service into a high volume service, I typically would say, explore participation or joining the network. Obviously, because this is the lowest out-of-pocket cost for the patient. In scenario two, you're still billing the health plan. Their fee is still $2,000, but because you're out of network, the patient may have less coverage, and they're going to have the rest of that balance due as out of pocket plus the difference in your fee. So this is really where your fee comes into play. Option one, okay, your fee of $3,000 is irrelevant because that gets discounted down to $2,000. You're accepting what the health plan pays. Scenario two here, well, you're telling the insurance obviously you're out of network and we're not going to accept your fee. That means you're telling insurance, I'm billing this patient $3,000 and I'm collecting $3,000 from the patient. The health insurance company may reimburse the patient, they may reimburse your practice, it doesn't matter. But at the end of the day, you're looking at a different scenario here where the patient has a much higher out-of-pocket balance. And you may have a higher revenue because you're billing your full fee, you're collecting your full fee. It's going to be less from the insurance, it's going to be more from the patient. But now you compare $2,000 out of pocket to $400. You're probably not going to get as high of a case acceptance, and you're probably not going to get as many referrals from physicians. And finally, the third case is even with a prompt pay discount. I think that ends up being like a 15 or 16% discount. If you discount your fee to accommodate a cash patient, well, that $2,500 is still 100% out of pocket for the patient. So you get the idea. Now, the question we always get: what dental services are billable to medical insurance? And the answer is it depends. It's not straightforward. However, there are some common themes. First, diagnostic procedures that may cover a discovery of pain in the oral cavity, infection, maybe a congenital anomaly or deformity that's known. So these diagnostic procedures, it could be an exam. An exam is considered diagnostic typically in the dental world. It's not really a preventive exam to medical. Radiographs and or other advanced imaging, biopsies, or lab testing. So if it's to determine one of these things, it may be covered by medical. There are non-surgical treatments. So for abscess infection, usually with an underlying medical condition. One example would be tooth restoration. Could be due to chemotherapy, an eating disorder. Obviously, you've got a treatment of TMJ dysfunction by appliance manipulation or injection. And then you've got oral appliance therapy to treat sleep apnea. Those all fall under the non-surgical treatment for some underlying medical condition. And then finally, the surgical repair treatment due to infection, injury, or trauma to the teeth or periodontal region. Or it could be a treatment in preparation of an upcoming medical procedure. The standard surgical procedures of the oral cavity with a primary medical diagnosis is what oral surgeons are typically billing to medical insurance, but they do have procedures. Obviously, they bill to dental insurance too. So at the end of the day, always work with your billing company, or if you've hired a biller, hopefully it's someone with coding experience to understand what are the appropriate codes and medical policies. We're going to get into that in a little bit too. Now, specifically, what treatments? So I have a list here. There's a couple slides. I'll just touch on a few here. I've highlighted oral appliance therapy for obstructive sleep apnea. Mentioned that quite a bit here today because that is probably the most prominent medical policy for a dental-related service that exists on the medical side, probably outside of the standard oral surgery policies for oral surgeons. I had mentioned exams and radiographs. Tissue grafting and augmentation that have to do with a non-cosmetic reason. If you're doing an extraction and there's a medical reason or a medical cause that that forced you to extract the tooth, that's when an extraction could be considered medical. Same thing with implants. So if the tooth is lost due to some type of a trauma, cancer is a really good example. If there's a tumor or cyst, atrophy of the bone, where the dentures can't sit and it's affecting the ability to eat, and it's affecting patients' nutrition. Now you're starting to get into oral systemic, and if you've got a medical diagnosis, that's when an implant can be covered. DNA and bacterial laboratory testing, this is becoming popular. There's a couple of great programs out there. I'll reference Perio 360 by Paul Jacobs, who's a good friend of mine and a client. This could be performed and billed to the medical insurance for suspect of some type of, again, another underlying medical condition. Sinus lifts and Lefort procedures for the cleft lip and palate, or class 3 malocclusion. I'll also mention the frenectomy. So in children, the lingual frenectomy, way more popular as far as medical coverage, simply because it could be a diagnosis of I have trouble pronouncing this word, typically ankyloglossia. So that's when obviously a medical necessity comes into play, right? That's the theme here. So it could be impacting their speech. It could be impacting their eating. It could be even an infant that's unable to latch for breastfeeding or bottle feeding. So these are scenarios, and I won't go into the rest of these, but the common theme here is there are many different procedures. If there is a medical cause or a medical diagnosis and why you're providing that treatment, and typically these would, some dental offices will bill the dental insurance and they'll say, look, it's denied. This needs to be covered by medical. So we recommend don't double dip and don't concurrently bill. If something is very specific and you're confident, maybe you billed it before to medical and there's a medical policy on it, well, sure, we can bill it to the medical insurance first. Oftentimes, because it's a dental procedure, you may want to try billing for dental insurance first. They may pick up a few codes. So if there's a series of codes, maybe they'll pay for a couple, and then you could go and submit the others to medical insurance if they deny and then say this is covered by medical. If it's typically part of a routine procedure, dental care, well, obviously it's not. Let me see what else here. Injury, trauma, so these are fairly common. These cases too could be covered by a workers' compensation or auto insurance policy. This is a really good example of when a medical billing service can verify benefits, do coordination of benefits. So there might be multiple payers in the mix. You just don't want to suck up resources and time of your dental office to worry about billing the workers' comp, billing the autos insurance, then billing medical. It is a fairly complex process and a painful one, albeit. But in those cases, that's typically what you may be looking at. Some other general considerations. Is there a code? Is there an actual code that somebody, hopefully who has a certified coding certificate or medical billing experience, has identified that, yes, this is a proper, or from the medical policy of the payer, this is a proper code in the medical world. So there's CPT codes as opposed to CDT codes. The CPT codes are the medical codes that need to be submitted with the medical claim, oftentimes, and always with an ICD-10 diagnosis, which you're familiar with anyway. You always need to consider that the medical plan may require a pre-authorization. It's different than a predetermination or pre-D in the dental world. You can still get a predetermination in the medical world, but it's a little bit different. The predetermination in the medical world, you're asking really for a peer-to-peer review for a dental director or medical director at the health plan to look at your case for medical necessity. It's a little bit more of a guarantee that, yeah, from a clinical perspective, they'll approve this case and they'll cover this case. A pre-authorization is a standard requirement typically for higher volume cases, surgical cases, and advanced radiology, where if you're going to be billing a certain code, every time you need to go through their pre-authorization department, provide some basic documentation, and typically it's a team of nurses, under the medical director's supervision, that will simply go down the list and say, do you have all the required documentation to support this case being paid? Always consider, you might need some pretty robust clinical notes, both on your side and from a referring physician to meet that medical necessity. I mentioned double dipping here, concurrently billing dental and medical insurance. Don't do it. And just be aware that, if this is something you're going to take on, the claim submission process is, it's quite intense. So there's modifiers, there's code orders, there's a different claim form. So all things to consider. Just a little bit about dental sleep medicine here. Every medical policy, just about every plan I've seen has some type of medical policy or reference to oral appliance therapy for sleep apnea. So it is a very widely covered procedure. There's many professional societies that offer continuing education and credentialing. And there's guidelines established, published research papers and policies and rules. So it's, you're really getting into a lot, but the good news is that there's decent reimbursement for this. Even though there's a high documentation burden and a lot of requirements for the dental office, it can be a very lucrative field, as many of you do know. It is catching the attention of payers. So those of you who are billing or considering billing, getting into sleep medicine, you got to know what you're doing. If you're a cowboy out there and you think this is the wild, wild west of setting whatever fee you want to set simply because someone told you, and kind of foregoing all of the standard guidelines, you're going to get yourself into trouble. And we've seen many cases go to trial, and many dentists either lose their license or have to pay back quite a bit because they ignored the regulations and the policies that were set forth by payers. This another link here below. We'll share this link after, but if you're thinking about getting into this, or you're just getting into sleep, the AADSM, which is the American Academy of Dental Sleep Medicine, has all of the published guidelines, practice parameters. They have standards of care that they've issued and some other position papers that are very valuable. So if you don't know those and you're doing sleep, I would recommend you brush up. And if you're getting into, that's a good place to start. This is an example of what is required for oral appliance therapy. Once again, if you are a current provider and offering oral appliance therapy and you don't have a checklist like this, or this is, foreign to you, I would stop what you're doing and make sure you really understand these are your requirements. This is not made up by me or Lyon Dental or any one particular payer. This is pretty standard across the board. If you're going to be not only providing treatment, regardless of billing, but more or less for if you are going to be billing a health plan, and particularly Medicare, you need to know this stuff. So the point of this slide is, there's a lot to know and there's a lot to keep track of from a documentation perspective and from a process, your inter-office policies and procedures. Who's assigned to do all of this work? Do you have a billing team? Do you have people who can gather the documentation, get the pre-authorization submitted, etc.? And that kind of brings us to the next portion of this. And we're going to talk about for the last 15 minutes here, and then we'll open it up for questions. How do you manage all of this? You're a busy dental office. Boy, this seems like a lot. There's a lot of things to know. And then once I get into it, billing, documentation, how do I keep track of it all? It's a really good question. Oftentimes, when you get into some of these more advanced treatments that you're billing to medical, you're tracking some different metrics and outcomes. There's a different lab ordering process. If you're ordering a custom fabricated appliance from a dental sleep lab or TMD appliance, there's different specifications to your treatment that you need to be aware of. There's different financial reporting too. You may even have a separate set of books. Maybe you've opened up a separate practice, a side-by-side business to your dental practice. Now you're running a different set of books. So you got to have a means to manage your AR. Are you connected to a medical clearinghouse for electronic claim submission? Who's preparing your claims? There's a lot of medical insurance that you need to load to be able to bill into your software. There's a lot of billing rules. This might be a case or might be treatment that generates incoming and outgoing referrals from the medical community at large. How are you going to track those? How are you going to organize all of your clinical notes and the other documents that are required from payers when you need to get a pre-authorization? And obviously the internal and external communications. How do you manage all of this? Well, the answer is with software. So as I'd mentioned and Danny had mentioned before, our software called MD Fusion is built on an existing medical EHR, but it's been tailored for dentists, and we've really focused on dental sleep medicine and TMJ at this point. But the truth is, if you have the right software, it doesn't have to be our software. I hope it would be, because ours is very robust and capable. Is your system capable, period? It could be your dental software. I doubt it can do all of these things. So you might have to look into a separate software program to be able to manage all of this. Hopefully, that software program can make your office run more efficiently and not the opposite. It has to be a time saver. You have to be able to manage the coordination of care that might come with, a procedure on a patient who's got some very complex medical conditions, and you're not the provider who's going to manage those medical conditions. So there's a pretty strong communication point between, you and the referring physician or the physician of record, simply because they're going to be taking over the medical management of the patient. You're simply stepping in to provide a needed treatment. Most importantly here in the center is medical necessity. Are your clinical forms and your patient forms set up that serve you to be prepared in a world that requires you to have complete and accurate documentation? Obviously, you're hoping that your documentation is is in order so that if you ever get audited, it will happen, I guarantee you. If you bill on a regular basis and you get into one of these treatments, at some point you're going to face some kind of audit. It is, you can be assured, as taxes and death. Your regular dental software might not be equipped to manage this. Integrated billing. So if you're doing all of your documentation in the software, well, you should probably be billing from that same software. You should have some kind of integration with a billing team or a biller that you've hired to come in and take all of the clinical notes and apply them to pre-authorizations and responses to claims that maybe have been on hold. So having an integrated billing service is very key, not only from the financial perspective, but also to meet all of the documentation requirements. And I always like to recommend a system that's cloud-based. It's a bear to have to download a program and maintain it on your server. There's a lot of things that can go wrong, and hopefully your internet is up the majority of the time. But cloud-based application opens up a whole bunch of new possibilities, including integrations with other applications. It services really the coordination of care, makes your software accessible at all times. I'm going to talk a little bit about the SOAP note, and the reason being, any one of these procedures, it could be a surgical procedure, it could be a frenectomy, it could be a sinus lift. You're doing a very advanced procedure, a surgical procedure on a patient. It could be oral appliance therapy. It could be a short biopsy. All of these situations would require some type of an examination. You're going to see this patient before, and you're going to examine them. And if you're going to be billing your case to medical, that often comes with billing for an exam. If you are going to be billing for an exam, you have to understand the SOAP note. Obviously, SOAP stands for Subjective Objective Assessment Plan. Those are just simple headers and reference points of what do you need to have in your exam and why. Hopefully, your exam is not being handwritten, and hopefully you're not in a software program that you have to type into a box for 20 minutes or more. The goal is that you'd be able to utilize some information from electronic patient forms and a software program that can help you and guide you not only from a time perspective, but also to meet all of the requirements. If you're going to be billing this exam to a medical payer, you better know what you need to do to meet this, because the only evidence, if you get audited, and health plans love to audit people billing for exams, especially for the first time, or if maybe your fee might be a little bit higher, or you're a provider as a dentist that maybe doesn't bill these on a regular basis, they love to audit exams because oftentimes the office fails in meeting the documentation requirement, and it's all about the note. There's nothing else you can prove to a health plan other than your SOAP note. Most importantly, you need to have a chief complaint. You need to have history of present illness and some type of patient health history on file, especially if it's a new patient exam. You need to have a brief review of systems, your examination. So all of those elements meet the subjective part of your exam. Your examination, your physical examination itself, is the objective portion. Then you need to have your assessment, and you need to demonstrate that you're making some kind of clinical decision making. It is your professional assessment. Why is this patient here? How are they doing? What is my assessment as far as how this patient, what's the status of this patient? And then finally, a plan. What are we doing? Now, there's another link here. This might be the most important link in the slide deck here. It's a link to a website called EM University. EM stands for Evaluation and Management. Whether you know it or not, if you're billing an exam, a medical exam code to a payer, It's called an evaluation and management service. So they have an extensive set of examples of the level of codes, and based on that level of code, what elements do you need to meet? And the truth is, it's not about your time. It's about the components of your exam, and I can't stress this enough. So here's an example. It's probably not easy to read, but the point I'm trying to make is you can see the extensiveness of a SOAP note here for a new patient exam. This happens to be a dental sleep patient where the provider is billing a 99203. This is a mid-level exam code for a new patient. And as a dental provider, there are certain providers who can meet the requirements of billing for this type of code based on time. You as dental providers oftentimes are not. It doesn't meet your scenario, and I won't really go into details, but just know that just because you spent 45 minutes with the patient doesn't mean you can bill a 99204 or a 99205. Your note and all of its components should dictate how the level of complexity that you're billing. I always do recommend, though, especially as a dentist, to not bill for those higher exam codes. Unless you're an oral surgeon, it is very hard to meet the medical complexity that's required in a higher E&M or an office visit code. So these are some common mistakes that we see in servicing clients. I'm not trying to shed light on negative, but it's something really to understand that some of these, as you read through them, seem pretty basic, but you wouldn't believe what we see as a billing service on our end. That it makes us nervous because there's audits and there's takebacks. There's licensure that's on the line here. So I'm not going to read through these. I've touched on many of these before. At the end of the day, if you've got a good system, that might include software. It might include a biller that you've hired. It might include a third-party billing team. It might include another industry vendor or a consultant that can help you avoid these mistakes. Don't go at it all alone, basically, because I guarantee you some of these mistakes you're going to be making. If you end up making too many mistakes, you fall within the spectrum of problems. Now, on the left is something that happens on a regular basis. People make errors. Maybe it was a coding mistake. Maybe it was a mistake on a claim, which really just requires a resubmission of the claim. So either it gets stopped by the payer and they say, you need to resubmit this, it's wrong, or they deny it, and maybe you were missing a piece of documentation, and we had to resubmit it. So that's a standard error. That just happens. We try to avoid those mistakes with a sound process and a sound system and software, but errors and mistakes happen. As you move further down the line here, that's when it gets a little scary. Some payers will provide audits, and if you're continually providing unnecessary services they don't deem medically necessary and billing for those services, they could call those waste. That might result in possibly departicipation if you do have a contract. Further down the line, you might be dealing with payment recoveries in a category we call abuse. This would be upcoding. So if you're billing for a code, that exam is a really good example. If you're billing for a very high complex exam, but you can't prove that you met that complexity for medical decision making or patient health history and conditions that you're addressing or treating, and you bill for a higher code than you should, this is abuse, and they can take those monies back. Finally, we get to fraud. You're dealing with heavy fines, your license being revoked, and some people at jail time if it's absolutely egregious. This would be upcharging where you're charging insurance a much higher fee than what you might be charging a cash patient, or you're egregiously discounting copays and deductibles, or in many cases that you hear that kind of make the news, billing for services that were never actually provided. So that's fraud. I'm going to leave you with a few tips here. I'll go through. We've got about 20 minutes left on this call, and I want to open up for some questions. Make sure you got a reasonable fee schedule that's updated annually. Your fee should be higher than Medicare and should be higher than the highest paying commercial or private payer. Always collect deductibles and copayments. Do not waive them. And, you know, if you're providing a discount, it should either be in the form of a prompt pay discount for a cash paying patient, or if the patient has financial hardship and can prove that financial hardship, it's documented, then you have the ability to apply a discount. If you are participating with a plan, you should not be balance billing that patient. Obviously, you want to avoid arrangements where you're receiving an incentive for a referral, especially with Medicare. That violates the Stark and the anti-kickback statute. Avoid charging a management fee. I've had several of these questions where dental offices are trying to make up for seeing this patient maybe on a regular basis, where they had to provide a series of visits or a series of adjustments, and you know there's no code to bill for them, and for some way, shape, or form they found this code that does not apply for dentists, but it's a management fee for care management services that other allied health medical providers would bill insurance plans for. It doesn't apply for a dentist. So there are no access or admin fees that I'm aware of that dentists can bill for. Make sure you have a system, software, inter-office policies and procedures, billing, a certified billing company or a certified coder. Be prepared to have to prove your medical necessity through documentation and read the policies of each payer. It's amazing how many people don't know a payer that they bill on a regular basis, what the medical policy actually says. Take 10 minutes and read it, and you'll probably learn a whole bunch. Obviously, know your population, and explore options for participating in those networks. If you're contracted, if you're participating, know what your contract terms are. Know the nuances of the different plan designs. We talked about HMO and Medicare Advantage. Bill appropriate codes. Obviously, we talked about the E&M or the office visit guidelines, and utilize an experienced medical biller that can help you with that. Avoid those higher complexity office visit codes. Unless you're an oral surgeon, I do not recommend billing for any of these exam codes. I don't care if you think you meet the criteria, most likely you do not. And then for sleep, there's a lot of things for sleep that I showed you the checklist. Specifically, make sure you have a qualified sleep study and a written order. If you don't, for just about every payer, you can be in trouble. And don't forget your proof of delivery. Avoid billing patients for any services in the first 90 days after delivering the appliance. Always bill on the date of delivery, not the impression. It's different when you're doing sleep and you're delivering an appliance as opposed to seating a crown. And only provide the PDAC approved appliances for Medicare. So there's a list of Medicare approved appliances and some additional guidelines that you really need to be aware of for Medicare. So be careful if you're billing Medicare. So that concludes the content portion of this presentation. I really want to thank Danny Bobrow and Virginia Norton of AIM Dental Marketing. They're a great team, and I appreciate you hosting this webcast. And this is
very kind.
Yes, by all means. This is my contact information. Again, you'll have it on the recorded session. So if you're interested in the services we provide, our medical billing services and our software, MD Fusion, you can reach out to me directly here by phone or by email. And then for our participants here today, I really want to thank you. And we're happy to offer a special discount. So if any of our attendees are looking for software billing services, we're offering a 50% discount on our implementation fee. It's usually $1,500 to sign up. and get the software and get you all set up with billing. And we're discounting that 50% to $750 through the end of this year. So thank you, everybody. And Danny, I'll turn it back over to you.
Thank you very much, Jeff. That was great. I appreciate it. I'm also appreciative that you did agree to extend this offer to our attendees, as well as to give them time, because as we discussed, this is not a easy decision. If people view changing or adding to their practice management software, they don't take that decision lightly. And so thanks not only for the generous offer, but also the generous time frame of people being able to sign up on or before the end of the year.
My pleasure.
With that, yeah, let's dive into questions. I can tell you right now, we're not going to be able to get to all of them. We've had a very engaged audience, which we love to see. I will also say that, as is often the case, some of the questions are asked earlier in the presentation, and to some, at least to some extent, they're answered. But nonetheless, I'm going to pose them just because I want to be sure that that whoever asked them, usually the questions are asked by an individual, but they're being considered by many attendees. So with that, let's just dive in. The first question is, why would a practice be inclined to operate two different software programs? Are there integrations or ways to operate with a single solution?
Yeah, that's a great question, and probably going through everybody's mind as we say software, and oh my gosh, more software.
Right.
You know, I think when we spoke about some of the shortcomings maybe of the standard dental softwares out there, to be able to provide the clinician with all of the clinical forms, the patient forms, the medical billing, and all the other documentation support to meet medical necessity. That's why many providers who are a little bit more committed, I would say, you know, if they're going into a new treatment and saying, look, we're expanding our practice to provide TMD or surgical procedures or sleep, they're making a little bit more commitment, so they understand the need for this other program. However, there are some programs out there that do have those capabilities as far as integration, maybe with your dental sleep, your regular dental practice management system. And our software, I'll just mention this because on that question, in the future, we are priming to have a full capability of dental charting, dental billing, along with all of the medical, charting and medical billing requirements we already have. So this is a pretty heavy lift. It's in the works for us, and something that practices may wish to consider in the future, so you don't have to operate on two software platforms.
I do know that you've been working on that for some time and that it is approaching fruition. I wasn't sure if you were going to share it or not, but that's really exciting news, and I'm sure that everyone's going to want to hear more about that when the time is right. I also want to share with you a truly unsolicited endorsement from one of our attendees, because as you know, we'd invited our clients, your clients, to attend, and some did. This is from Dr. Bogro. I'm just going to read what he said. I can attest to the value of MD Fusion software and medical billing services, and helping me follow all the rules in being a dentist and billing out for medical services, especially with oral appliance therapy. Earl is a client of mine as well, and he managed to create from a general practice a dental sleep medicine practice very successfully. Not overnight, but he has arrived, and he's enjoying himself. Lyon does a great job. I've used other companies, but none are as thorough. So thank you for sharing that, Dr. Bogro.
It was very nice, Dr. Bogro, and we're delighted to have you as one of our partners. And we learn a lot from our clients. So it just makes us better.
Yeah. And actually, I learned about you from Earl. Now that I think about it, so it was a really good to have him on the call. What's wrong with an office training their staff to bill medical insurance as opposed to working with a third-party billing company? I think you covered that. But,
yeah. There's nothing wrong with it. However, as you get into some of these more complex treatments or even a higher volume, it is very hard for someone who doesn't have the medical billing experience. I'm not saying that you can't teach someone and that someone can't be trained. That's couldn't be further from the truth. But oftentimes, the medical billing world, unfortunately, it really is. It's sad how complex it has to be. With the claim preparation, there are modifiers, code orders, and kind of managing the process of a claim denies, or if a claim is stopped before it even goes through adjudication. What do you do? And it's in those scenarios where someone with really good medical billing experience and a certified coder can keep your office out of trouble and can keep your office running efficiently. So there's nothing wrong with it. I would recommend if an office is considering, that person go through a class and actually get a certification instead of maybe getting trained over the weekend or getting trained
or being asked to wear just another hat, right?
Exactly. Yeah.
This is something that I'm a concept which I'm asked to address frequently in my capacity as a dental marketing consultant and service provider. But my advanced degree is in marketing, but my undergraduate is in economics, and among other theories we learned are the theories of comparative advantage, which posits that no matter, even if you're great at everything, you should do the thing that you are most best at. And I have a number of clients who I think they're Renaissance men and women. They like to do many things, keep them interest, and that's fine. And I kind of summarize it by saying, doctor, you may be as good a marketer, you may even be a better marketer than me, but you're a heck of a better dentist than I am. And really, you should be focusing, and this extends to your team. You should be focusing on what you are most best at, and recognize that will earn you. Now, there are other factors besides money. If you find it stimulating and you like that sense of control, that's fine. As you said, just recognize that it is a specialized field, and if you want to internalize the function, it actually makes sense to work with an outside vendor while you're mastering the concept. Anyway, in my opinion, you can view working with a company like yours as a means to an end, if you like, and then the likelihood is you're going to find it so liberating that you're not going to proceed down that path anyway. But I think you answered it thoroughly and sufficiently. Next question is, will my medical charges ever be challenged by Medicare?
Charges, it could be. Any payer will look at their book of business, and they may audit the providers who have charges that would be outside of the norm. It's not to say that they would do something about it, but we've heard of cases that payers have visited, and I don't know if Medicare would really do this, but they would do it more from an audit perspective. If your charges are so egregious and outside of the standard curve, it would definitely throw up some red flags, because basically there's no way that your charge could be considered customary or reasonable unless it was a very, very different type of technology or treatment that you were providing. They could choose to take, sanctions and not allow you to participate, or, stop your billing privileges. Now, from a payment perspective, the plan's only going to pay what they pay. So, in most scenarios, your charge is your charge, and then if you accept what the plan pays, well, the rest gets written off anyway. So in some cases, your charge is irrelevant, but that doesn't mean your charge should be egregious.
Yeah, and that raises a more general point, because you mentioned earlier in your presentation to avoid being an outlier, I think you said.
Right.
what and you're right. If they're going to discount and they're going to pay what they're going to pay anyway, why? I guess I could see why they might care, because that might. I'm not really sure, because if they're going to pay what they're going to pay, why do they even care?
Well, if you have a contract with them, it becomes irrelevant. However, that where the practice can really get stuck is, what happens if a cash patient walks through the door? Are they charging that patient? Something reasonable comparative to their charge to the insurance company? So that's really where a practice can get in trouble. If a practice does not have a contract, oftentimes the payers are either contracting at a percentage of charges, and now the practice has to worry about balance billing if they're not accepting that insurance. So there's some other factors even beyond the payer that the practice needs to consider with higher charges, particularly when they're not contracted.
Okay. How can I explore which services would be covered under medical before actually jumping in and making a commitment?
Yeah, there a lot of the health plans have their medical policies that are published. So you could look, for instance, if it's Blue Cross or if it's United Healthcare that's the biggest payer. Those medical policies are available to search. I would also, that's when, asking your peers, attending industry events or continuing education, and or, working with a third party, and they can really tell you. But, at the end of the day, like I had presented with the conditions that are payable by medical, there's a lot of what ifs for dentist billing medical. So it really does depend on the patient's condition. But, I would start with the medical policies, because they will oftentimes specify what conditions would meet the criteria for covering an extraction or covering another maybe surgical procedure by a dentist.
So there's no database right now that's a comprehensive source to just look or to query to see if it comes up or not. You got to talk to the different plans, because different plans cover different.
Yeah, every plan is different. There are a lot of common, the medical policies oftentimes will follow some type of common theme, but there's always a list of codes. There's resources online, whether it's Find a Code or even Medicare. We as a billing service has a list of common procedure codes that dentists may bill to medical. Some are more oftentimes covered because they naturally would treat a condition that might be more systemic or medical in nature. However, you're correct, Danny. There's no hard and fast database that says, well, if I do this code, it will be covered by these plans. It's because, again, it all depends on the diagnosis. It all depends on the patient's condition.
Gotcha. Well, we've got several questions left. I'm trying to pore over them to see which one would be, because a number of these have been covered to varying degrees. Here's one. Let's finish with this one. In your experience, do you find that by focusing on medical reimbursement, a practice actually ends up doing more good for the practice? That is to say, this is sort of like a variant of Adam Smith's invisible hand, that while pursuing your own personal benefit, you wind up helping your society. So in other words, that is to say, can medical reimbursement lead to adoption of more oral systemic health-related procedures and protocols?
Yeah, certainly. I think we've seen offices who might be interested in starting a procedure, and the dentist may have gotten some training and education, and they've developed their policies, and they start doing medical billing. And as they get into the world of medical billing, and they start to see maybe a different cohort of patients walk through their door, they may realize that other patients have conditions beyond what I'm doing right now that I could treat, and now I've got the resources to be able to actually make it worthwhile. And it's not just about billing. It might be, I'm able to do my clinical documentation, or I understand the process of exploring a medical policy, getting my medical necessity, and now you're opening up your doors to obviously do more good for a larger group of patients than what would be your standard dental population. So absolutely, Danny.
Yeah, I do think that it sort of opens doors. It gives you more of a medical mindset, and understanding the reimbursement landscape, I think, inevitably leads to understanding procedures and having a confidence and comfort level with that nomenclature can only help in terms of building your professional referral network, which leads to more referrals, but also better treatment. Because I think, when we collaborate, it's nice to have a fully stocked toolbox so that whenever when you have a hammer, every problem's a nail. So we like to avoid that narrowness, which is what oral systemic practice model really is all about. So, I want to thank you again very sincerely, Jeff, for doing this. An indication of how much fun and how valuable it was is how quickly the time went. So, in fact, we are past time. So I just want to thank you again and remind everybody that in a few days you'll receive, if not sooner, an email. You'll get an email with instructions on how to receive your CE credit, as well as a link to the recording of this webcast, an evaluation and quiz for you to complete to get your CE credit, again with the compliments of AIM Dental Marketing and Lyon Dental. And I now want to invite you to mark your calendars for Thursday, November 19th at 6 p.m. Central Time, when my guest will be Dr. Leonard Tao, who will introduce you to the wonderful and profitable world of world-class case presentation. The apt title of his presentation is The Art of the Sale. Until then, this is Danny Bobrow, thanking you for your ongoing commitment to practice perfection. And once again, thank you, Jeff Burton.
Thank you very much.
Goodbye, everybody.